So without further ado, I would like to thank the organizer and especially the previous speaker, Dr. Anshul and Dr. Akhil, who have done a great job in discussing exon 20 insertion at length. But I will try to brief with some other complexity of interpretation of exon 20 insertion. But before that, I would like to have a couple of my introductory slides. Can I have my slides, please? Next slide. Next slide, please. So if you see this slide, which has already been discussed by Anshul, that the frequency of exon 20 insertion mutation varies demographically depending upon which part of the world we are talking about. Especially in India, when the EGFR mutation in general is higher as compared to the other parts of the world, the exon insertion 20 also rises up. Approximately 1/10 of the EGFR mutations will be EGFR insertion alterations. But if you see the diagram in the lower right hand side, these are the different technologies used to identify EGFR insertion mutations, and you will find that depending upon whether it is a PCR based technology or NGS based technology, the percentage of EGFR insertion increases. As was discussed by Dr. Akhil, that the COBAS method is not that great as compared to the NGS, especially when you have so many insertions alterations available. So you have to keep in mind before really making a point that whether the patient have exon insertion 20 mutation present or absent depending upon the type of test utilized. Can I have the next slide, please? So again discussed by Anshul in the previous discussions, but I would like to emphasize once again that we have plenty of exon insertion, exon 20 insertions where you can see, and then we have this C helix, the near loop and the far loop, which are important to know about and which have implications in terms of prediction to response to drugs. But now we have very new drugs which are better off, which can be predicted to respond to both near loop alterations and the far loop alterations at the same time. But if we are able to identify who are the people or the patients who have C helix loop alterations starting from the location of 761 till 774, those patients may benefit with the first generation TKI or the third generation TKI at the same time. So you can help them and avoid the amivantamab treatment, which is a costly affair. Next slide, please. Again, previously discussed by Anshul, but a simple comparison of the EGFR activation. When we compare the EGFR 19 deletion versus exon 20 insertion, there is a concept of pulling and pushing actually. So once the amino acids are deleted, the C helix is pulled in and the ATP binding sites is open and the ATP can easily bind. And similarly, when the exon 20 insertion, that is insertion of couple of amino acid, pushes the C helix, once again there is an opening of the ATP binding site. So both of the mechanisms are same, but there are different implications of the TKI to bind these ATP in order because of some steric hindrances at the same time. So such a basic concept. Next slide, please. So again discussed that the near loop alterations are the commonest alterations. The earlier drug like positinib was more sensitive to near loop alterations as compared to far loop alterations, but the newer drug like amivantamab have both near loop and far loop response, good response. The mutants are quite less, practically very less, but if they are present, they may respond to the first generation, second generation, or third generation TKI for that matter. Next slide, please. So we have finding the exact location. As I already mentioned, that the near loop sometimes fare better in terms of responses as compared to far loop, but does not make a major difference. Near and 90% of the cases do have these alterations located in the near loop. Next slide, please. Next slide. So this is the NCCN recent guidelines which talks about the use of amivantamab with chemotherapy when you have EGFR exon insertion 20 mutation. And next slide, please. So this is the list of other treatments where mobocertinib has already been withdrawn, but there are various other treatments available. You can see the long list, and these are, a couple of them are in different trial setting, but eventually you will see more of the options coming very soon into the market. But amivantamab is the one which is available and can be used for majority of our patients. Next slide, please. Next slide. So I'm going to talk about a case study to the real world interpretation, and this is a gentleman, an elderly gentleman who came to with a metastatic presentation, and the comprehensive genomic profiling was carried out upfront on the tumor biopsy, which showed that the patient had PDL1 of more than 50%, EGFR exon insertion 20 mutation with the location you can see there's an insertion of 4 amino acids between 773 to 774. Along with that, there's an EGFR amplification. Again, we have MTAP loss, CDKN2A loss, TET2 mutation, and TP53 loss. And definitely the question about amivantamab is not into a discussion, but the question about whether we can use immunotherapy plus minus in this case or not are to be discussed in this particular case. Will it be beneficial for adding chemotherapy in this case, or do we have some other options? So can we have the next slide, please? So if you see the CDKN2A loss and MTAP loss, which talks about the 9p21 loss here, we think that this seems to be a very cold macro environment, and here the use of immunotherapy may not be very useful. So rather than choosing immunotherapy, the better choice would be just using amivantamab and the chemotherapy for that matter. But what are the implications of EGFR amplification when you are using the amivantamab, which we do not know much about it? So I'm quoting a paper which I came across. Can I have the next slide, please? Next slide, please, again. Next slide. Next slide. So this is a paper which talks about that the patient who have exon insertion 20 mutation along with EGFR amplification, and if you are treating them with the TKIs, the response rate and the survival is far different. So the coexistence of EGFR amplification results in a resistance to the TKI at the same time. So in this particular case, amivantamab monotherapy may not yield that very good response what we normally expect, like 40% response rate what is reported, but you may have a quick or early failure in this case. Ideally in this case, the patient should have been offered amivantamab with chemotherapy, which is already a part of the guidelines, but the complexity of all this interpretation whenever you do the NGS needs to be discussed in the molecular tumor board, which is the right option for the patients. And also discussed by Akhil that if you have coexisting mutation like ALK or any other EGFR activating mutations in exon 21 or 19, you may have to have a different take on the decision of the treatment actually. So with that, I think I will thank the audience for listening patiently. And if there's any question, I can take that, please.